Chapter 14, Mammo, Prometheus Lionheart, MD. Highest yield tip. Obviously the amount of pathology in breast imaging is extremely limited. Additionally, most of it will not project well on the computer monitors in all testing centers. As a result, a lot of the eye tests that make practical mammography difficult are unlikely to be shown on the test. Instead, focus in on next step style thinking when you study this material. 341. A brief overview for the complete novice. Many foreign graduates have had little or no experience with mammography. I'll try and give you a very brief overview before I get into the testable trivia. In America, women are told they need to have screening mammograms done once a year. Because breast cancer is common and scary, most women will get this done, and will continue to get it done into their 90s. They will literally take people from the ICU who are in cardiogenic shock down to X-ray to keep them up to date on their screening mammograms, usually at the patient's request. I want you to think about mammograms in two categories: A, the screener, these are the people who are coming in once a year, and have no symptoms other than being female, and B, the diagnostic, these people have a symptom, palpable lump, nipple discharge, breast pain, etc. These two are handled totally different. Nomenclature is rigidly controlled with regard to reporting. BLRADS is a book of approved vocabulary words for describing the findings, and a system for reporting results based on a percentage of risk. The basic idea is that you use scary words like speculated to describe things you think are cancer, and benign sound words like fat density to describe things you think are not cancer. Here are some basic scenarios. I'll explain all the stuff in the chapter, and we can revisit some more scenarios at the end of the chapter. This is just for you to get a feel for how this works if you have never been around it before. Don't spaz if you are lost, it will be clear by the end of the chapter, and then we will do them again with some quizzing. Law: a 50-year-old woman comes in for a normal annual screening. Highest yield tip. Obviously the amount of pathology in breast imaging is extremely limited. Additionally, most of it will not project well on the computer monitors in all testing centers. As a result, a lot of the eye tests that make practical mammography difficult are unlikely to be shown on the test. Instead, focus in on next step style thinking when you study this material. 341. A brief overview for the complete novice. Many foreign graduates have had little or no experience with mammography. I'll try and give you a very brief overview before I get into the testable trivia. In America, women are told they need to have screening mammograms done once a year. Because breast cancer is common and scary, most women will get this done, and will continue to get it done into their 90s. They will literally take people from the ICU who are in cardiogenic shock down to X-ray to keep them up to date on their screening mammograms, usually at the patient's request. I want you to think about mammograms in two categories: A, the screener, these are the people who are coming in once a year, and have no symptoms other than being female, and B, the diagnostic, these people have a symptom, palpable lump, nipple discharge, breast pain, etc. These two are handled totally different. Nomenclature is rigidly controlled with regard to reporting. BLRADS is a book of approved vocabulary words for describing the findings, and a system for reporting results based on a percentage of risk. The basic idea is that you use scary words like speculated to describe things you think are cancer, and benign sound words like fat density to describe things you think are not cancer. Here are some basic scenarios. I'll explain all the stuff in the chapter, and we can revisit some more scenarios at the end of the chapter. This is just for you to get a feel for how this works if you have never been around it before. Don't spaz if you are lost, it will be clear by the end of the chapter, and then we will do them again with some quizzing. Law: a 50-year-old woman comes in for a normal annual screening mammogram. She has no symptoms, and is just following the recommendation. She gets two standard views, a cranial caudal view (CC), and a medial lateral oblique view (MLO). The radiologist is in a hurry because he has 200 of them to read, so he just calls it normal by RADS 1. The patient returns to the screening pool, and will get imaged again in 1 year. She is relieved to know she doesn't have cancer. IB: the same 50-year-old returns 1 month later after she feels a lump. This is no longer a screening study but instead a diagnostic because she has a symptom. She gets another mammogram, this time with a palpable marker on the image. She also gets compression spot views, smaller paddle, over the palpable area. In the area of the palpable finding there is a cluster of calcifications. They were present in retrospect on the mammogram performed 1 month prior, but are new from the year before. Because they are calcifications, you need magnification views to fully characterize them. On the mag views you describe them FLS, coarse heterogeneous. Because they are new from the prior year they must be biopsied, but you aren't done yet. Diagnostic mammogram usually includes an ultrasound, not because of the calcifications, but because there was a palpable finding. Just remember, no female with a palpable gets out the door without an ultrasound. You ultrasound the area and find no mass. The next step is to biopsy the calcs, which are BR4-4. Intermediate suspicion. You recommend stereo to biopsy them, not ultrasound, because you couldn't see them with ultrasound. The results yield fibrocystic change, which you agree is a possibility given the BR4. When you agree that the biopsy results make sense with the imaging clinical scenario, you use the word concordant. The results were concordant, said the resident to his attending. You inform the patient of the results. She is relieved to know she doesn't have cancer. 342. L. 2. A 60-year-old woman comes in for a normal annual screening mammogram. She has no symptoms and is just following the recommendation. She gets 2 standard views, a cranial caudal view CC, and a medial lateral oblique view MLO. The radiologist is in a hurry because he has 200 of them to read, but still manages to see a new mass in the medial breast on the CC view. The breasts are pretty dense and it's hard to find it on the MLO. So the radiologist calls it an asymmetry and BR0 because more workup is needed. The patient returns in a week for a diagnostic study. She is convinced that she's gonna die of breast cancer. You can hear her crying in the waiting room. She gets a diagnostic study with spot compression over the mass on the CC view, as well as ML and MLO views. You do manage to see the mass on the CC, and in the superior breast on the ML view. The mass is well circumscribed, round, and equal density. Because she is getting a diagnostic workup, she gets an ultrasound too. Before you go in the ultrasound room, you guess about where the mass is going to be. Since it's medial and superior, on the right breast you guess 2 o'clock. You locate it quickly, and find it to be an anechoic cyst common in women going into menopause. You tell her it's consistent with a benign cyst. She cries with joy and thanks you repeatedly for saving her life. She sends you cookies and brownies every year at Christmas with very long letters about how you saved her. She uses a lot of religious references that make you uncomfortable. Some years you throw the food away without eating it, other years you give it to the techs. The simple cyst was reported as a BR2, essentially 0% chance of cancer. 3. A 45-year-old woman comes in for a normal annual screening mammogram. She has no symptoms and is just following the recommendation. She gets the 2 standard views, CC and MLO. The radiologist is in a hurry because he has 200 of them to read, but still manages to see a new mass in both the MLO and CC views. Because this is a screener, he still has to give it a BR0, you never BR4 or BR5 off a screener. She returns for additional imaging as a diagnostic patient with spot compression views. A spiculated, irregular, high-density mass is seen. She is placed in an ultrasound room for further characterization. The ultrasound shows an irregular, circumscribed, antiparallel, hypoechoic mass, with posterior shadowing and an echogenic halo, all the scary bad words. You are certain the mass is a cancer based on these features, so you scan the rest of her breast looking for other tumors, and you look in her axilla for abnormal nodes. You find several enlarged lymph nodes in her axilla. You recommend ultrasound-guided biopsy of both the mass and the most suspicious lymph node. You give her a BR5, 95% chance of cancer. The biopsy results come back as fibrocystic change. This result is not concordant with the findings you made on mammography and ultrasound, so you recommend surgical excision. Gross path shows a high-grade invasive lesion. 343. SEC110N1 Anatomy. Nipple. The nipple is a circular smooth muscle that overlies the fourth intercostal space. There are typically 5 to 10 ductal openings. Inversion is when the nipple invaginates into the breast. Retraction is when the nipple is pulled back slightly. They can both be normal if chronic. If they are new, it should make you think about underlying cancers causing distortion. The nipple is supposed to be in profile, so you don't call it a mass. The areola will darken normally with puberty and parity. Nipple enhancement on contrast-enhanced breast MR1 is normal, dawn or call it Paget's. Fibroglandular tissue. The breast mound is fibrous tissue with fat, ducts, and glands laying on top of the anterior chest wall. The axillary extension is called the tail of Spence. The upper outer quadrant is more densely populated with fibroglandular tissue, which is why most breast cancers start there. There is usually no dense tissue in the medial/inferior breast and retroglandular regions. These are considered danger zones, and are often where the cancer hides. Danger zones, where there is usually no dense fibroglandus/AR tissue. Cooper ligaments. These are thin sheets of fascia that holds the breasts up. They are the tiny white lines on mammography, and the echogenic lines on US. Straightening and tethering of the ligaments manifests as architectural distortion, which occurs in the setting of surgical scars, radial scars, and IDC. Breast asymmetry. This is common and normal, usually, as long as there are no other findings, lumps, bumps, skin thickening, etc. For multiple choice, an M-dottometric breast should make you think about the shrinking breast of invasive lobular breast cancer. If the size difference is new or the parenchyma looks asymmetrically dense, think cancer. 344. Lobules. The lobules are the flower-shaped milk makers of the breast. The terminal duct and lobule are referred to as a terminal duct lobule unit, or TDLU. This is where most breast cancers start. Lactiferous sinus. Major duct. Lobules. Ducts. The ductal system branches like the roots or branches of a tree. The branches overlap wide areas, and are not cleanly segmented like slices of pie. The calcifications that appear to follow the duct, linear or segmental, are the ones you should worry about cancer with. Lactiferous sinus. Milk from the lobules drains into the major duct under the nipple. The dilated portion of the major duct is sometimes called the lactiferous sinus. This thing is normal, not a mass. Blood supply. Lymphatic drainage. The majority, 60%, of blood flow to the breast is via the internal mammary. The rest goes to the lateral thoracic and intercostal perforators. Nearly all, 97%, of lymph drains to the axilla. The remaining 3% goes to the internal mammary nodes. 345. Axillary lymph node levels. Level 1, lateral to P minor. Level 2, under the P minor. Level 3, medial and above P minor. Rotor node, between the P minor and major. Axillary node levels. The axilla is subdivided into 3 separate levels using the pectoralis minor muscle as a landmark. Supposedly drainage progresses in a stepwise fashion, from level 1, level 2, level 3, and finally into the thorax. Rotor nodes. These are the nodes between the P minor and major. They have a fancy name which usually makes them high yield. However, rotor was German and test writers tend to prefer French-sounding trivia. The only exception to this is Nazis. German-sounding medical vocab words named after Nazis are fair game. To save you the trouble of looking it up, Rotter died before Hitler took power, so he wasn't a Nazi probably. Since they probably aren't gonna ask the vocab word, the only other conceivable piece of trivia I can imagine being asked would be that these are at the same level as level 2. Metastasis to the internal mammary nodes. If you can see them on ultrasound, they are abnormal. Isolated mets to these nodes is not a common situation, maybe 3%. When you do see it happen, it's from a medial cancer. More commonly mets in this location occur after disease has already spread into the axilla, in other words, it's spreading everywhere. 346. Sternalis muscle, this is an ant mini. It's a non-functional muscle next to the sternum that can simulate a mass. About 5% of people have one, and it's usually unilateral. Sternalis, only on CC, never on MLO. The main testable trivia is, 1. WTF is that, recognize the ant mini, and don't get tricked into doing a biopsy on it etc. 2. How you see it. It is only seen on the CC view. Handling this in real life is all about the old gold. Find that thing on the priors even better as a CT, CC only, never on the MLO. 347. Breast development physiology. The milk streak is the embryologic buzzword to explain the location of the normal breast and location of ectopic breast tissue. Just know that the most common location for ectopic breast tissue is in the axilla, second most common is the inframammary fold. Extra nipples are most commonly in the same locations, but can be anywhere along the milk streak. At birth both males and females can have breast enlargement and produce milk, maternal hormones. As girls enter puberty their ducts elongate and branch, estrogen effects, then their lobules proliferate, progesterone effects. If you biopsy a breast bud, why would you do that? You could damage it and potentially fuck up breast development. And then get sued. Follicular phase, day 7 to 14 estrogen dominates. Best time to have both mammogram and MRI. Luteal phase, day 15 to 30 progesterone dominates. This is when you get some breast tenderness, max at day 28 to 30. Breast density increases slightly. Pregnancy, tubes and duct proliferate. The breast gets a lot denser, more hypoechoic on US, and ultrasound may be your best bet if you have a mass. Perimenopausal, shortening of the follicular phase means the breast gets more progesterone exposure. More progesterone exposure means more breast pain, more fibrocystic change, more breast cyst formation. Menopause, the floppy stage, lobules go down. Ducts stay but may become ectatic. Fibroadenomas will degenerate, they like estrogen, and get their popcorn calcifications. Secretory calcifications will develop, but not for 15 to 20 years post-menopause. Hormone replacement therapy, breasts get more dense, even more so estrogen-progesterone combos. Breast pain can occur, typically peaking in the first year. Fibroadenoma, who like to drink estrogen, can grow. 348. L_. High-yield trivia regarding breast anatomy physiology. The nipple can enhance with contrast on MRI. This is normal, not Paget's. Most cancers occur in the upper outer quadrant. Most cancers start in the leninal duct lobule unit, TDLU. Majority, 600/0, of blood flow is via the internal mammary. Mets to the internal mammary nodes are uncommon, 3% seen in medial cancers. Axillary node levels 3 to 1 medial to lateral stemmalis is usually unilateral. And only on the CC, never on MLO. Brea, L tenderness is max around day 27 to 30. Mammography and MRJ are best performed in the follicular phase, days 7 to 14. Dawn T biopsy. A prepubescent breast you can affect breast development. Perimenopause 50s is the peak time for breast pain. Cyst formation. Fibroadenomas will degenerate, buzzword popcorn calcification, in menopause. Secretory calcifications, buzzword rod-like, will develop 0-20 years post-menopause. Are what you know about lactation. Key by JHE3, when I chirp shoddy chirp back. Density, as mentioned above, the breast gets a lot denser in the third trimester. Mammograms might be worthless, and ultrasound could be your only hope. In other words, ultrasound has greater sensitivity than mammo in lactating patients. Density trick, pituitary prolactinoma, or meds, classically antipsychotics, can create a similar bilateral increased density. Biop_y, you can biopsy a breast that is getting ready to lactate. Lactating, you just need to know there is the risk of creating a milk fistula. If you make one, they will have to stop breastfeeding to stop the fistula. The fistula can get infected, but that's not very common. Galactose/E, this is one of those benign fat-containing lesions that you can BR2. This is typically seen on cessation of lactation. The location is typically subareolar. The appearance is variable but can have an mini look with a fat fluid level. It's possible to breast abscess these things up. Lactating adenoma, these things look like fibroadenomas and may actually be a charged up fibroadenoma. They like to drink estrogen. Usually these are multiple. If you get pressed on follow-up recommendation for these, I would say 4 to 6 months, postpartum, post-delivery, or after cessation of lactation via ultrasound. They usually rapidly regress after you stop lactation. 349. Section 2. Technique, artifacts. Basics. As I mentioned in the introduction, a screening mammogram starts with 2 standard views, a cranial caudal view and a medial lateral oblique view. Cranial caudal view (CC). Technically adequate. The first step in reading a mammogram is verifying that the technique is satisfactory. For the purpose of multiple choice, there are a few easy ways to test this. The posterior nipple line, this is drawn on the MLO from. You need to touch pectoralis muscle to be adequate. Then on CC, you draw a line from the nipple back towards the chest wall. To be adequate, you must be within 1 centimeter of the length of the posterior nipple line. Medial lateral oblique view, MLO. 350. Technically adequate CONT. So other points and trivia. Ideally, the inframammary fold should be visualized. Camel nose is the buzzword used to describe a breast on MLO that has not been pulled up and out by the tech. The nipple should be in profile in one of 2 views to avoid missing the subareolar cancer. Relaxed pectoralis muscles are preferred, convex instead of concave, showing more breast tissue. Positioning trivia. When do you get a LMO view? The MLO is the standard, but sometimes you need a LMO. The answer is women with kyphosis or pectus excavatum. Or to avoid a medial pacemaker, central line. MLO view trivia. The MLO view contains the most breast tissue of all the possible views. When using spot compression views, a big point is the recommendation to leave the collimator open, giving you a larger field of view, and helping to ensure that you got what you wanted to get. Small paddles give you better focal compression. Large paddles allow for good visualization of landmarks. When using magnification views, a CC and ML, true lateral, are obtained. You get a ML as opposed to a MLO to help catch milk of calcium. When using a true lateral view ML vs LM, using a true lateral is useful for localizing things seen on a single view only, the CC. A trick I use is whatever I said on the screener is the last letter I'd use on the callbacks. In other words, if it's lateral on the screener, you want an ML on the diagnostic. If it's medial on the screener, then you want a LM on the diagnostic. The reason is that you are moving it closer to the receptor. If you see the area of interest on the MLO only, not the CC, you should pick ML, because most 70% of breast cancers occur laterally. This would make a good multiple choice question. 351. Artifacts. Blur can be from breathing or inadequate compression, typically along the inferior breast on the MLO. It can be tricky to pick up. The strategy I like to use is to look at the Cooper ligaments. They should be thin white lines in the fat. If they are thick or fuzzy, it is probably blur or edema. If there is skin thickening, think edema. Blur, Coopers are too thick toward normal skin. Grid lines, basically mammograms always use a grid, unless it's a mag view. That would make a good multiple choice question actually. No grid on mag views. So the grid works by moving really fast and only keeping X-rays that move straight in. You see blur in 3 scenarios: 1. Patient moved, 2. Exposure was too long, 3. Exposure was too short. Grid lines, 3 examples: horizontal lines. 352. SEC110N3 Localization. You are trying to find around 3 to 8 cancers per 1,000 mammograms. Another way to ask this is to say that you are supposed to have a positive predictive value, PPVT, of around 4%, in other words anything other than a BRL or BR2 on a screener. This is demanded by the various regulating bodies. Be aware that certain areas can sometimes only be seen on a single view. For example, the medial breast on a CC may not be seen on MLO, and the inferior posterior breast on MLO may be excluded from the CC. That makes these areas high risk for missing a cancer. Medial breast can be excluded on the MLO view. Inferior posterior breast can be excluded on the CC view. It's recommended to look at mammograms from 2 years prior, if available, for comparison. Makes it a little easier to see early changes. Localizing a lesion, only seen in the MLO view. This is a very basic skill, but if you had absolutely no interest in mammography, or just terrible training, a refresher might be useful, as this is applicable to multiple choice tests. A lesion that is seen in the MLO only will rise on the true lateral, ML, if it is medial on the CC film. A lesion that is seen on the MLO only will fall on the true lateral, ML, if it is lateral on the CC film. The popular mnemonic is lead sinks and muffins rise, L for lateral and M for medial. ML. Muffins rise, L//. Lead skinks MLO CC 353. Localizing a lesion, only seen in the CC view. Sometimes you can only see the finding in the CC view. If you want to further characterize it with ultrasound, figuring out if it's in the superior or inferior breast could be very helpful. One method for doing this is a rolled CC view. Rolled CC view. This works by positioning the breast for a CC view, but prior to placing the breast in compression you rotate the breast either medial or lateral along the axis of the nipple. Your reference point is the top of the breast. If you roll the breast medial, a superior tumor will move medial, an inferior tumor will move lateral. If you roll the breast lateral, a superior tumor will move lateral, an inferior tumor will move medial. In other words, superior tumors move in the direction you roll, and inferior tumors move in the opposite direction you roll. The superior vs inferior is inferred based on how it moves when you, the tech, roll the boob. If ____IR. Cancer in superior breast only seen in CC view. Cancer in inferior breast only seen in CC view. Rolled medially CC view moves the cancer medial. Rolled medially CC view moves the cancer lateral. Rolled laterally CC view moves the cancer lateral. Rolled laterally CC view moves the cancer medial. 354. L_. Section 4 BL RADS. L_. BIRADS is an acronym for Breast Imaging Reporting and Data System. It was developed by the ACR to keep everyone on the same page, in a similar way the DSM was developed for psych. You can't have people just calling stuff breast nodules. BL RADS assessment categories: 0, incomplete 1, negative 2, benign finding S 3, probably benign 4, suspicious abnormality. Some people use 4A, low suspicion, 4B, intermediate suspicion, and 4C, moderate suspicion. 5, high GI suggestive of malignancy. 6, known biopsy, proven malignancy. BIRADS 0, this is your incomplete workup. They come in for a screener, you find something suspicious. You give it a BIRADS 0, and bring them back for spots, mags, or ultrasound. You would also BL-RADS 0 anything that required a technical repeat, blur, inadequate posterior nipple line, camel nose, etc. BI-RADS 1, it's normal. BI-RADS 2, benign findings. Examples would be cysts, secretory calcifications, fat-containing lesions such as oil cysts, lipomas, galactoseals and mixed-density hamartomas. Multiple bilateral well-circumscribed similar-appearing masses, this is BR2 unless one is growing or different than the rest. The general rule is to not ultrasound these things unless one is palpable. Multiple foci, this MRI finding, is also a classic BR2. 355. BI-RADS 3, a key point is that BR3 by definition means it has less than 2% chance of being cancer. This is often a confusing topic. You can only use BR3 on a baseline. You can't call anything BR3 that is new. The typical BR3 scenario is, 45-year-old comes in for screening, and has a focal asymmetry. She gets called back for diagnostic workup with spots and ultrasound. She is found to have mass with imaging features classic for fibroadenoma. This can get a BR3, and be followed, some places follow for 2 years in 6-month intervals. Any change over that time UPS it to BR4 and it gets a biopsy. Things you can BR3, finding consistent with fibroadenoma focal asymmetry that looks like breast tissue, becomes less dense on compression. Grouped or clustered round calcifications. What if it's palpable? This is a controversial topic. Classic teaching is that palpable lesions cannot be BR3. However, recent papers have shown that a palpable lesion consistent with a fibroadenoma has less than 2% chance of cancer. Some people think the new BI-RADS will change this rule. I really doubt they will paint you into a comer on this one, given the controversy. BI-RADS 4, this is defined as having a 2 to 95% chance of malignancy. Some people will subdivide this into 4A, 4B, 4C depending on the level of suspicion. Ultimately you are going to biopsy it, and be prepared to accept a benign result. BI-RADS 5, this is defined as 95% chance of malignancy. When you give a BR5, you are saying to the pathologist, if you give me a benign result, I'll have to recommend surgical biopsy. In other words, you can't accept benign with a BR5. BI-RADS 6, this is path-proven cancer. 356. Basic flow, these are essentially your choices in a workup. Screening mammogram, no symptoms. Diagnostic mammogram. BR0, you made a suspicious finding, and they need a diagnostic workup. BR0, technical repeat for blur. / inadequate positioning etc. BR1, totally normal. BR2. Multiple bilateral well-circumscribed similar appearance masses. BR2, redemonstration of an unchanged previously worked-up thing, a cyst etc. /BR2, you work it up and it's a benign thing, fat-containing lesion, cyst etc. This returns to Skrierung. Either a callback, BR3, very specific situation where you or someone with are dealing with a baseline screener, now a symptom, called back. Findings meet one of the 3 things described above, fibroadenoma, fat with breast tissue, group of round calcs. This gets 2 years of follow-up. BR4, suspicious finding, but you aren't convinced it's cancer. In other words, you would accept a benign result. This gets a biopsy. BR5, suspicious finding, that you are convinced is cancer. In other words, you would not accept a benign result. This gets a biopsy. 357. BI-RADS terminology. In addition to the 0 to 6 babysitting, the various regulating bodies have decided there are only a few words they will trust you with, depending on what modality you are using. Plain mammography. Mass, this is a space-occupying lesion seen in 2 different projections. Describing the mass, you need to cover 1. Shape 2. Margin 3. Density 1. Shape, round, oval, irregular, ROI 2. Margin, circumscribed, obscured, microlobulated, indistinct, spiculated, 3. Density relative to breast parenchyma, fat density radiolucent, hypodense, low, isodense, equal, hyperdense, high. Trivia: of all the possible descriptors, margin is the most reliable feature for determining benign vs malignant. Asymmetries: unilateral deposition of tissue that doesn't quite look like a mass. Asymmetry: this is a density, only seen in one view, that may or may not be a mass, and is often a term used in screeners for BR0 prior to callback. Global asymmetry: greater volume of breast tissue than the contralateral side, around 1 quadrant's worth or more. It's gonna get a callback and then BR2D on a baseline. Focal asymmetry: this is seen in 2 projections, might be a mass, needs a spot compression. Developing asymmetry: wasn't there before, now is or bigger than prior. Ultrasound. Describing the mass, you need to cover 1. Shape 2. Orientation 3. Margin 4. Echo pattern 5. Posterior acoustic features. 1. Shape, round, oval, irregular, not round or oval. 2. Orientation, parallel, wider than tall, not parallel, taller than wide. 3. Margin, circumscribed, indistinct, angular, microlobulated, spiculated. 4. Echo pattern, anechoic, hyperechoic, hypoechoic, isoechoic, or complex, cystic/solid. 5. Posterior features, none, enhancement, shadowing. 358. MRI. There has recently been a vocabulary change on the lexicon, and I'm going to briefly cover the changes. Background parenchymal enhancement: this is a newly added BIRADS feature. In the literature they specify that this description is based off the first post-contrast sequence. Sounds testable to me. The categories are none, minimal, mild, moderate, and marked. Lesion analysis: there are 3 basic categories for this. Foci, SMM. You don't need to describe shape and margin on these. They are too small. Mass, SMM. This will have shape, margin, internal enhancement characteristics, and T2. Non-mass-like enhancement, distribution, internal enhancement, T2. Describing masses: shape, round, oval, and irregular. The word lobulated has been removed from the lexicon, so expect that to be a distractor. Margin: circumscribed, irregular, and spiculated. The word smooth has been removed from lexicon, so expect that to be a distractor. Internal enhancement patterns: homogeneous, heterogeneous, rim, and dark internal septations. Enhancing internal septations and central enhancement are not terms in the new vocab, and will likely be distractors. T2 signal: this is a new feature of the lexicon. Hyperintense, greater than parenchyma, on T2, greater than or equal to on T2, greater than or equal to water, on T2 fat sat. NMLE distribution: focal, linear, linear branching, segmental, triangle shape pointing towards nipple, suggestive of a duct. Regional, large area, not a duct, multiple. Regional, 2 or more regions, and diffuse. NMLE internal enhancement: homogeneous, heterogeneous, stippled, multiple punctate foci, clumped, looks like cobblestone, clustered ring. This is a buzzword for DCIS or JDC. Reticular and dendritic have been removed and will likely be distractors. 359. MRI BIRADS Kant. Kinetic curves are also described. I'll talk about this more in the breast MRI section. Associated findings: you are allowed to talk about nipple retractor, skin thickening, edema, invasion of the P muscles, pre-contrast signal, and artifacts. Implants: when you talk about implants you have to describe the type, silicone vs saline, location, retroglandular vs retropectoral, and luminal features like radial folds, keyhole, linguini, etc. I'll cover this more in the breast MRI section. 360. SEC110NS calcifications. Calcifications can be an early sign of breast cancer. The earliest sign, actually, according to some. Calcifications basically